HR My Health Record data. My name's Leanne Wells. I'm the CEO here at Consumers Health Forum, and pleased that we've got so many people registered for this webinar. I think we've got over 140 people registered, so I think it just goes to show how important a topic it is. I'll just make a few comments by way of introduction to Nicole, Jarvis and Andrew Pearce. Andrew from the consulting company that's been working on the consultations, Nicole who's leading the policy on this in the department. But by way of a few introductory remarks from CHF, we're in the process of framing our submission to this process. Our broad view at CHF is that My Health Record and the data, the rich data set that will be bringing together is exactly that. It's a rich data set that can be mined, analysed and used in the public interest for better evidence-based policy making. But that said, obviously our constituency is saying very clearly to us that best practice safeguards, world-leading safeguards around privacy and security of data is absolutely a paramount important consideration for the framework. The other point to make too in introducing this webinar is that this is a special webinar in that it's the first time that the Department and Health Consult have presented a synthesis because they are at the end of the consultation process itself. They've been on the road for quite some time, running state and regional workshops, taking written submissions, taking online surveys. So what you're actually getting today is a synthesis of the emerging themes. One, to share those with you and an opportunity then to take your reactions, comments, questions on those. So I think that's probably by way of introduction. I'll hand over to Andrew. Obviously, it's Consumer Health Forum focus. We'll be making our own submission to the process, and we really want to draw out, and put a consumer focus on the conversation today. So I'll hand over to Andrew and Nicole to take you through the themes. Thank you.
Thanks, Leanne, and good afternoon, everyone. As Leanne said, my name's Andrew Pearce from Health Consult. I'll be, chairing and facilitating this webinar today. In terms of how it's going to be run, we've got an hour for this particular webinar, and through that we'll be stopping throughout the presentation to respond to questions and talk about questions on a particular area as we move through, and then at the end of the webinar we'll actually open the floor to more general questions and anything else that's been raised. So I guess a few points on that. We will get to as many questions as we can through the webinar, but certainly make sure you do send in your questions. Those questions that we don't get around to, we will respond back to them after the webinar through the Consumer Health Forum. So I'm trying to get to the slide. There it is. I was trying to move that. It didn't move before. So as I mentioned, my name's Andrew Pearce. I'm one of the senior team managing this project. Leanne, who you met earlier, alongside me now is Nicole Jarvis, who's the Assistant Secretary of Digital Health Branch at the Department of Health. So we'll be running this today. As Leanne said, the purpose of this webinar, the consultation period began on the 5th of October and closes midnight tomorrow night. That's the 17th of November. The webinar, as Leanne introduced, is going to be an overview of the community consultation process to date and some of the themes that have emerged, and we'll have some good discussion about those as we do it. This is obviously a key part of informing the framework development which we're doing at the moment. So I might now spend 5 minutes or so going through a bit about the project and providing a little bit of context, and then we'll pause for some questions, and then we'll get into the themes that have come out today. So a little about the project. As it says there, we've been engaged to develop a framework for the secondary use of data in the My Health Record system, whether it be for research, policy, planning, system and evaluation activities. Under the My Health Record Act, information held in the My Health Record system may be collected, used and disclosed for any purpose with the consent of the healthcare recipient. In addition, one of the functions of the operator, which is the Australian Digital Health Agency, is to prepare and provide de-identified data for research and public health purposes. But before these provisions of the Act will be implemented, a framework for the secondary use of My Health Record must be established, and that's what we're seeking consultations on, and this webinar is one part of that consultation process. A bit of context. Secondary use is defined as using the information in My Health Record system for purposes other than the provision of direct health care to the individual person, which is the primary use. The use of data solely for commercial and non-health related purposes is considered out of scope in that secondary use framework. And secondary use has been seen to involve and have potential future healthcare benefits for patients and recipients around knowledge gathering and disease and treatment, understanding service delivery and improving service delivery in health, supporting healthcare goals, and also assisting providers in meeting your consumer needs. A recap on what's in My Health Record system. There's two components. There's the non-consumer-oriented data, which you can see on the screen there has a number of components to that, including specialist letters, referrals, diagnostic imaging reports, and the like. And that's non-consumer-oriented data. And then you have the consumer-oriented data, which includes things like health notes, health summaries, health observations, and the like. I guess it's important to note that this is some of the components that are in My Health Record to date. My Health Record as a system will continuously be updated to include other pieces of data over time, you would expect, as will the depth of data provided within the system. And so it's important to note that the framework itself will take into account that evolving nature of the type of data in the My Health Record system, not just the data that's in there today. So I guess we might pause there now that we've talked a little bit about the context and the project's objectives, and just see what kind of questions you have and go through some of those, and then we might then proceed on to some of the key themes that have come out of the consultations to date. Just wait for some questions to come up. Just waiting. Okay, I understand that there's been some questions are being furiously typed as we speak. So what we might do is just wait for a moment, and then we'll maybe then move on to the themes and come back to these questions. Okay, here comes a question. Okay, so the first question is around the context of the project. I'm confused about what is in scope and what is out of scope in terms of secondary use framework for My Health Record. Nicole, did you want to?
Yeah, sure. So essentially, the legislation provides for what the primary use is of My Health Record data, and that is around providing direct healthcare to an individual patient. So we consider that any purpose outside of that would be secondary. So things like using data for research, using it for health service planning to improve treatments, medications, there's a whole range of different options around what the data could be used for, but it's basically, if it's being used for a purpose other than direct healthcare to the individual, it would be considered secondary.
Okay, thank you. So we have another question. What are the provisions around children and the use of their secondary data?
So for children currently, their records, if they're under 14, are managed by their parent or authorised representative, depending on their situation. So it would be up to that parent or representative to make a decision on the behalf of that child. Once the child reaches 14, they can take control of their own record and make those decisions for themselves. And there is a provision that allows children to take control earlier than that if there's advice from their healthcare provider that they are able to represent their own interests.
Great, thank you. Okay, we might see if there's one more question, or otherwise we might move on. Oh no, we'll have one more question. Here it comes, emerging technology. On scope, I understand use of data solely for commercial and non-health related purposes is out of scope. What is the expectation where it is used for more than one purpose, at least one being commercial?
Great question. So we have recognised, by putting that distinction around solely commercial, we recognise that there will be purposes that have both a commercial outcome but also have a public health benefit. So that's what we'll be looking for, is the balance of public good as compared to the commercial interest. So for instance, you might have a pharmaceutical company who wants to use the data to increase their market share. That would be a solely commercial purpose and that would be out of scope. However, if they wanted to use the data to improve a drug that was going to have a public benefit for the people who are using that, potentially life-saving treatment, we would consider that the public good outweighed the commercial interest in that situation. So the framework will have to deal with what the principles are around that, getting that balance right, so that the governance body and the data custodian can make really clear decisions about when the public good outweighs the commercial benefit. In terms of non-health related purposes, what we're trying to do there again is around this public health good. So if the data is being used for health and related, so health, social services, welfare, human services, well-being, those sorts of purposes we would consider health related purposes. If it was something around tax data or those sorts of things, we would consider that out of scope. So again, it comes down to what's the public health benefit of the use of the data.
Okay, great. We might now move on to the themes, if we may. And here we go. So the first theme that's come out of the consultations to date has been around the consent to use of data by individuals. First of all, some of the comments and thoughts that have been provided to date include having a dynamic consent framework, preferred with options for the consumer. Service providers need to enable consumers' informed consent. How will reconsent be sought if the purposes change? The consumer's ability to share their own data, opt out of secondary use, provide consent for use of identified data, i.e. for some purposes but not others. The recognition of a need for informed consent about My Health Record program expansion in 2018, and also around consumer trust in government process will be critical to ensure the program's success. So these are some of the themes that have come out of the consultations to date around the consent to use of data by individuals. We might pause there for a moment for your questions on this particular theme, and let's wait for a few moments for your questions before we move on to the other themes. So the question is, will people be able to opt out of their data being used for secondary purposes?
So yes is the short answer. One of the things that we mentioned on the slide before was around a dynamic consent framework. And this has come up a lot in the consultations to date, where people are saying some people would like the option of a blanket opt-out or opt-in of secondary use. Others would like to be able to share their data for particular projects but not for others, or with particular users, for instance, researchers but not commercial entities, things like that. So what we're doing is the department will have a session with the Digital Health Agency and work through what functionality exists in the My Health Record system to allow us to have these access controls so that over time, if your wishes change, you're able to withdraw or add in your consent and potentially for different things. So another one that's come up in this space is around consenting to be contacted, to be involved in research. So general consensus has been that you might want to set some privacy settings around secondary use of data that happens in the background. But if you were to be contacted to be part of a clinical trial, for example, you might want to specifically consent to being contacted because that has more of an impact on your day-to-day life. So these are the sorts of things that we'll work through, but certainly people will be able to opt out of their data being used for secondary purposes.
Thank you. Okay, so the question is, what is the definition of de-identified that is being relied on? Is it a term that is not recommended in the NHMRC national statement?
Yeah, this has come up quite a lot in the workshops to date around terminology. For the purposes of this consultation process, the My Health Records Act actually identifies de-identified data for the purpose of research and planning purposes. And essentially what we mean by that is data that has had the identifying features removed. So things like name, address, date of birth, things that could be reasonably identifying an individual. It will differ in a case-by-case basis. So if there's a user of the data who has access to different data sources that when combined with My Health Record could identify a patient, we would need to restrict additional fields than just those personal identifiers. So that'll be a case-by-case basis and we'll have to set that out in the framework.
Thank you. Next question. The big issue for me is using this secondary use to promote patient involvement in research. How can we achieve that?
Yeah, that's a great one, and this has come up quite a bit, that people have said there might be a particular condition that's indicated in their record, or they're on a particular medication. There is either a recall for the medication, or there's a newer version of a device or medication for someone, or potentially a clinical trial for a condition that they have. And this is one of those things where we'd like to include a consent flag in the access controls that allow people to be contacted for research, and it potentially then gives researchers another avenue to source involvement from. So at the moment it's largely through their healthcare providers, and this could present another opportunity. So certainly that's something we're looking to do, particularly by including an access control that allows for being contacted.
Okay, great, thank you. Thank you. All right, we might now move on to the next theme, and we'll obviously come back to your questions on all the components at the end. So that need to move through. I'll do that. So the theme around uses of data is the next theme. So around that, people need to understand what the potential of the data is in order to inform the framework effectively. Around uses of data, balancing health and commercial/public benefit use of data. There's some reservations about allowing commercial use of data. And people would like to see clarity in the framework on things like the definition of what sorts of commercial users that would be allowed. There's certainly interest from the industry around the use for innovative purposes. What will be the principles for determining the difference between commercial and non-health uses? And balance and hold risk of release with the public good component. There's been some strong, good discussion around that throughout the consultation processes today. So around the theme uses of data, those are some of the key components. We might again pause there, some of your questions around the uses of the data aspect. See what questions you have. We might wait for a moment. Here they come. Okay, so the first question is, will the consent of de-identified data be managed by the system operator?
So the system operator and the data custodian may not be the same entity. This is something that's come up a lot in the workshops, is that the Digital Health Agency is the system operator. It has a particular skill set around running and operating the system. There's been questions about, is it perhaps more appropriate for the data custodian to be an entity that already has the skills, the knowledge, the governance structures to manage sensitive health data? We have a lot of those in the health space already, like the Institute of Health and Welfare, ABS and others, who currently use and govern large health data sets. So the consent of de-identified data will be managed by the data custodian, whoever that entity ends up being, and we're taking views on that through the consultation process. What we've heard so far is usually a preference for it not to be the system operator, in that having that level of independence over the data release allows for research questions that aren't necessarily tied to making the system or the government look good, but allow for that broader range of independent research.
Thank you. Next question. Okay, we'll carry on to the next theme. So the next theme, the third theme that's come out, is around the treatment of data. Some of the comments and the conversations we've had to date on this particular theme include around data quality and the coverage and usefulness for research purposes of the data within the system, the timeliness of the access to data, data security, both at the My Health record generally, but also that data that is released for secondary purposes and the security around that. Discussions around data linkage. Is it considered to be identified or de-identified data at the linkage stage, and how is that done and managed? How will the framework treat the linkage of data? It starts with the principles of the data linkage authorities as the models mature and has worked well over time. So there is obviously some principles and bodies out there that manage data linkages today in health and others. All different users will be subject to the same access pathways, e.g. researchers and government, for access to the data. And talk about the need for ethics committees to consider, control and manage this, the treatment of data processes as they do exist today. Those are some of the themes coming out from the treatment of data. We might pause there again to see if there's any questions on this particular theme around treatment of data. Just waiting for your questions. Here they come. Waiting on technology, thank you. So the question is, the data custodian should be the consumer. The question around managing data by the system operator was around them having the portal, including these access questions in their portal. That's more of a comment and a question. Access controls.
Yeah, so yes, the system operator will have the access control questions in the My Health record system, which you can access through the consumer portal, along with all of the other privacy settings and access controls that are currently in the system. So it will be in the exact same spot, and that will be managed by the system operator. In terms of the data custodian being consumer, we've had very strong feedback about consumer representation in the governance arrangements and in the data custodian arrangements, and that's certainly been taken on board for the framework.
Thank you. Question. Is around data linkage. Who will undertake the data linkage work, government or non-government?
So this has again been subject to discussion in the workshops, and I guess where most people are landing is that it should be an accredited linkage authority. We've already got a few of those around the country. They know how to do this work, their models are mature, they've got a good reputation, and they've got social license and consumer trust. So I expect that the framework will land in that place of using an accredited linking authority.
Thank you. Next question, if there is one. Okay, the question is, with secondary use, what other data sets can be combined with the health data, e.g. data sets held by Centrelink or ABS?
So I think the answer is that it will depend on the research question and the purpose. So really what we're looking to do is release or provide access to data that's going to derive a public health benefit. So if there is some public health benefit to linking data to Centrelink or ABS information, and there's particular research questions that are focused in that, there's an ethics committee approval and there's clear justification, then that could be considered. If the purpose of that is not to do a public health benefit, then the application would not be considered. So it really comes down to what's the purpose of the research, who is the user of the research and do we trust them, and what data sets is it they need access to, and how do we sufficiently de-identify those to protect the privacy of individuals.
Thank you. There's another question, we might move on to the next theme. The fourth theme that we have gathered so far in the consultation processes has been around, particularly around Aboriginal and Torres Strait Islander considerations. Some of the comments and the discussions have been around these matters, such as consent remains a sensitive issue, obviously, for Aboriginal and Torres Strait Islander peoples. There's further information required on things like why the data is being collected and what it's being used for, how will it be reported and to whom, any secondary data uses, including data linkages, where data will be stored, has been discussed. There's things where I need to consult with the Aboriginal and Torres Strait Islander communities before data is released. Clarity on the requirements around Aboriginal and Torres Strait Islander statuses, e.g. how will Indigenous identifiers be treated if they are inconsistent in a person's record. There's been some discussion around that. That is, if a person identifies as Indigenous in one forum or service but not in another. And social and cultural expectations around management of privacy concerns regarding data of deceased people. So there's been discussions and consultations specifically around these Aboriginal and Torres Strait Islander considerations. And those are some of the themes that have come out in the discussions today. We'll see whether there's any specific questions on those. And then we'll move to the rest of the webinar being around your remaining questions that you have at this time. Just waiting for the question. So the question is, has there been consideration of small populations in remote communities where individuals can be identified by other means other than demographics, such as being treated for a particular condition?
Yeah, this has come up quite a bit for us, and particularly when we have consulted in smaller areas in Cairns and in Alice Springs and Darwin, where it's clear that if you know a postcode and you know a gender and you know a condition, then you probably know that there's 2 or 3 people that data could relate to. There are well documented processes around small sample sizes, and we wouldn't look to make anything different to that. So there's already ways to protect, suppress, perturb data to protect small sample sizes. So we would be preserving those protections that are currently in place. The other point is one that I made earlier, which is when we assess the research applications, we will need to consider the access to the data that people already are holding. So if it's a user of data who's in a hospital or a health service who already has access to patient medical information, and then by getting some unit record data from My Health Record, they've actually opened up a whole lot more about an individual identified person, those would all need to be considered in the governance arrangements. We can't assume that there's no other data sets that can be linked to re-identify a patient. So in these small populations, that's something that we will treat very seriously and align with existing well-documented practices in the research space.
Thank you. Next question. The question is, will the same considerations given to Aboriginal and Torres Strait Islander populations be granted to other vulnerable populations, e.g. people with a very specific health condition?
I expect that will fall into the same category of small sample sizes, yeah. And how that's treated and protected. So yes, any population where it's a small sample size, it will have to be treated in the same protected way.
Thank you. This question is around what policies or procedures are needed for cohort studies that collect biological samples and other data from children linked to continuously update electronic health records.
So, I mean, that's an interesting one. Continuously updated electronic health records is interesting, but we won't be providing researchers with access to electronic health records. What we'll be providing on request and on approval and with ethics committee approval is perhaps an extract of the data, or perhaps access to an extract of the data. So they won't have updated electronic health records that they can go in and see change over time. What they'll get is a sample of data for a particular period and assessing the parameters that have been requested. So they won't have access to continually updated electronic health records. In terms of biological samples and things along those lines, we'll be sticking to the same ethics committee approval processes and the NHMRC statement on ethical conduct of research. We're not looking to reinvent any of the existing protections in the research space.
Thank you. Let's now go to the next question. And as I said at the start, we're going to be going for till about for an hour. We're about halfway through that time allocated now, and we've gone through the key themes that have come out. We'll just now continue to work through your questions the best we can over the rest of the webinar. But keep sending them in, as I said. Those questions that we don't get around to answering, we'll certainly be answering those through the CHF post the webinar. So please keep sending in your questions, and we'll get to as many as we can between now and the end of the webinar. So the next question is around, will research people have to meet minimum security standards for data retention?
Yes. So in order to get ethics committee approval, researchers always have to have standards around data storage, retention, destruction, and access. So those will remain. There has been a suggestion around potentially accrediting different organisations to have access to the data, which would mean that you've got a front-end process that assures all of those security and storage requirements prior to having them even access any data. So that's something that we're considering as well.
Yeah, and on a related note, it talks about what will, the next question is, what will happen if there is a data breach? Will researchers be able to cover this up, or will there be requirements to ensure that we are notified as a consumer, and will there be harsh penalties?
Absolutely. So secondary use of data is still subject to the same legal penalties that are already in the My Health Records Act, and that provides for heavy fines up to $630,000 and up to 2 years imprisonment for intentional misuse of My Health Record data. This will equally apply to researchers. They have mandatory reporting requirements in the My Health Records Act, so a researcher won't be able to cover that up. They will have to notify the system operator and the Office of the Australian Information Commissioner, and then they will have to then notify the consumer that there has been a breach of their data, the extent to that breach, the risk mitigations that are in place. So I think that's very well covered in the My Health Records Act already, and is much stricter than the restrictions in the Privacy Act generally.
Thank you. Next question. Okay, the question is, what is the process following this consultation? Will consumers get a chance to comment on the draft of the framework?
So the process after this is that Health Consult will go away and draft a framework. We expect that to come back into the department around February, at which point we'll have a stakeholder validation workshop, which will absolutely have consumer representation to go through that, and then we'll formalise the framework probably around March or April next year.
Thank you. Just waiting on the next question. What are the plans around data governance and transparency? Will each use of the data be publicly available?
So what we've considered and what we have tested in workshops and got really positive feedback around is having some sort of public register that sort of looks at, here's what the research is, the ones that have been approved and rejected. People were equally interested to know what didn't make it through the governance process, and then a link to any outcomes of the data, of the research that's been made of the data. So it may be that there's a published report at the end of that. It may be that the research didn't lead to a publication, but there's a summary on there that says, here's what we found and this is why it didn't make it to publication. And so that would allow us to have some kind of transparency with the public around what the data is being used for, what the outcomes are, and importantly, what the data is not being used for.
Thank you. Okay, if consent to secondary use is removed after data has been sent to the My Health Record system, will the historical data no longer be available? And can the removal of consent be applied to data sets already given to organisations?
Okay. So if you have data going up into your My Health record and then you choose to opt out of secondary use, the data that's in your My Health record will no longer be available. So it won't be available to any researchers for any purpose. However, if the data set's already been provided to a researcher, I expect that that would be difficult to retrieve that data at that point.
Yeah. Thank you. A question around how will people be informed of their options to opt out?
So as most people will be aware, the My Health record is going to move to opt-out participation arrangements next year. And as part of that process, the Digital Health Agency will be running a lot of communication activities with healthcare providers and with consumers to inform people about the opt-out process, to inform them about what a My Health record is, what the benefits are, how you can get in and set your privacy and access controls. And this will be one of those, how you set a privacy and access control. So secondary use will be something that people will need to understand as one of the benefits of the My Health record system, and then that there's actually access controls to allow them to control how that's used. So that will be part of the broader communications around My Health record changes next year.
Thank you. See what other questions are there. How will the governance processes remain apolitical?
Are you asking me, the Department of Health and Health, on that?
I guess no.
So, well, I mean, the framework itself will establish the governance processes. It will establish who the data custodian is, and generally consensus has been that that should be someone who's independent, someone who's potentially, like that Institute of Health and Welfare, is a blended sort of Commonwealth state. So we'll always have we'll always have representation of both sides of politics, and that the governance processes themselves not be subject to political influence. So that's the intention in the framework.
Yeah, correct. So, yes, we're looking at governance processes in that regard. Great. Question. I'm coming in another 20 minutes or so. The question is, with the My Health record account being a one-stop shop for medical records, what protections will there be for consumers from commercial entities such as health and life insurance sectors, from coercive financial incentives to reveal their data through consent for access?
Well, I'm not an expert on private health insurance legislation, but there are protections already in the health insurance legislation which doesn't allow them to financially incentivize things like revealing the data, but also doesn't allow them to adjust people's premiums on the basis of that information. So certainly in the secondary use of My Health record data space, we've already ruled out access for insurers. But this is more of with a patient consent. I think partly it's around consumers being informed, but also understanding that there is significant regulations and protections in the private health insurance legislation.
Yeah, correct. So what is the process if a consumer changes their consent from yes to no for secondary use or research? Does the access control opt-out of secondary use exist today for those already registered?
It doesn't, and that's because we aren't actually doing any secondary use. Yeah. So until there's a framework in place, we're not using the data for secondary purposes. So the information that's in the system is not being accessed for that purpose. So we haven't got a control in place at the moment, aside from just not doing it. If they change their consent, this is similar to what we mentioned earlier, that means that their historical data won't be used from the point that they have changed their consent to a no. However, if the data's already been provided to other organisations, I think that would be much more difficult to be retrieved.
Yeah. Thank you. The question is, it's all very well having legislation that says this and that, but it has to be enforced. That takes money and good people. Where is the guarantee that these resources will be available? This has certainly been one area that's been discussed through the workshops to date around once you've got a governance framework and you've implemented it, how do you check and enforce that people are doing what they promise that they would do, and that gets around to things like accreditation and audit processes.
Yeah. So I mean, we can't guarantee anything, but what we can say is that there will be a data custodian. They will have a very clear role in monitoring compliance with the legislation, and we will be looking to establish a cost recovery model which will allow that to be resourced. There's a lot of experience with cost recovery models from the Institute of Health and Welfare, from the ABS, from the TGA, for example, where you can break that down and allow you to have the reach. The TGA does quite a lot of monitoring and compliance and regulation activities, and that's all cost recovered. So we would be looking to those existing models to make sure that we can build a cost recovery model that allows that to be appropriately resourced.
Thank you. The question is, in terms of consumer awareness, language issues, what health literacy processes will be in place? Will the onus be on the carer or the individual to have data sets information interpreted for them?
No, so the Digital Health Agency already translates its materials into a range of languages, and it will continue to do that for the opt-out process next year, which will include the information around secondary use. So the onus won't be on the carer or the individual to have that interpreted. There will be language appropriate materials.
The question is, the My Health Record Act 2012 allows the system operator to refer records that suggest criminal activity to authorities. This would seem like a barrier to maintaining vulnerable people in primary care, such as people who use drugs, sex workers, etc., who will not want sensitive data mined from their record. How have consumer health groups such as CHF been responding to these concerns?
Can I just correct the record on that one? The system operator doesn't refer records suggesting criminal activity to authorities. There is a provision in the Act that allows enforcement agencies to request data from the system operator, and the system operator then has to be assured that that information is actually relevant and useful, and then makes its own reasonableness decision about whether to release that information. And to date, no information has been released to authorities for any purpose. So there will be no mining of the data from the system operator. The primary purpose of the system is around providing direct healthcare to an individual, and the policy setting has always been that any additional uses like referring criminal activities to authorities is not around direct patient care. It's not the primary focus of the system operator, and I think they've got better things to do with their resources, to be frank. So it would be in a very limited set of circumstances. It would be upon request, and it would be after a determination that that's a reasonable thing to do.
Right. Leanne, did you want to make any comment? Great. Thank you for that question. The question is, with respect to consent for children's data, what is the framework for when parents disagree re-consent?
So at the moment, there's a sort of an authorised person who makes the majority of those decisions. We won't be able to accept conflicting consent. So if there is disagreement, we would have to opt them out. So that's on the side of erring on the side of caution for the privacy of the individual, and that's how we would handle that.
Thank you. To the question. The question is, what are the plans for all Australians to be made aware of their options to opt out of both the My Health Record system and secondary use of data? Sounds like there will only be a small window, maybe 3 months, to let everyone know and for them to take the action they require.
So this is sort of further to what I mentioned about the work the Digital Health Agency is doing to educate healthcare providers and consumers ahead of opt-out next year. So it's a layered communications approach. There'll be a lot of work done in the early phases with healthcare professionals so that they're able to answer consumers' questions as they come in and help them to make those decisions. And then there'll be a range of consumer-facing activities which will run out through all of the usual networks, through primary health networks, through peak organisations, through consumer groups, as well as with state and territory health departments and health and hospital services and various others. So it's a very layered communication approach. The objective will be to reach every Australian. The 3-month window is based on what we did in the opt-out trials. So in late 2016, we did trials in the Nepean Blue Mountains and Northern Queensland PHN regions. And we actually found that the people who did opt out tended to do that in the first week and the last week, and there was very little in between. So the time frame in the evaluation was determined to be appropriate. However, there will be an extensive communications effort both for consumers and for healthcare providers, and a range of different options for people to be aware of the opt-out options and then to be able to exercise their choice.
Thank you. The question is, I believe there is a separate human research and ethics process for research that relates to the ATSI population, so Aboriginal and Torres Strait Islander population. Now, how will this framework ensure that ATSI HREA has been undertaken, so human research and ethics has been undertaken? Certainly, we've been, from a framework perspective, we've been talking about how the framework will treat Aboriginal and Torres Strait Islander peoples within the framework. We're getting views and on that, and looking at frameworks that exist both here and also overseas around that. So I don't know whether there's any other comments you'd like to make on that, Nicole, but we've certainly been getting feedback from them.
Yeah, it's come up in the workshops. We've gotten some really good intelligence from local Aboriginal and Torres Strait Islander communities and from their representative bodies, and we'll ensure that that's incorporated in the framework.
Yeah, correct. So yeah, so we're still seeking that advice and getting it. It's been comprehensively done at the moment. So next question. The question is, I'd like to push patient-led research again. With our data, so where are the ways for patients and patient groups to get research topics on the agenda? Yeah,
so we won't be proactively setting a research agenda around My Health Record data. It's really going to be led by the applications that we receive. So I think there are research strategies out there. There are research organisations who take on board different feedback, but we won't ourselves be sort of trying to determine where the research should go. So I think it's largely around advocating with research groups, noting that they will have to try to usually get grant funding to do things. So I don't think that there's a place in this framework for us to actively push that. What we're saying is the My Health Record system is there for the patient care. While we're doing that, we're getting a range of data that may be useful for other purposes. It would be a shame for that to go to waste. But what we won't be doing is actively going out there and trying to set up a research agenda around My Health Record data.
Will children, when they become adults, be required to reconsent, or are they denied the opportunity to withdraw, even though they may not want their secondary data to be used?
So the current arrangement is that when a child is approaching 14 and they're able to take control of their My Health Record, they get a letter from the Digital Health Agency to let them know you're approaching 14, you'll be able to take charge of your record, you can keep your parents on or take them off, you can set your own access controls, that sort of thing. So that will be an opportunity. Also, though, they will have people will have an ongoing opportunity with this being in the access controls to change their access controls as they go. So if for a particular period of time they don't want their data used for secondary purposes, but then they think actually there's some research going on that they'd like to be involved in, they can change their consent arrangements. Ultimately, if they had arranged either yes and then they decide they don't want to be involved, they can change that as well. So it won't be a one-off, but they will be prompted when they're approaching that 14 years of age stage.
Thank you. And as we mentioned earlier, the whole idea of discussion around dynamic consent as that person changes over time and as the data type changes, being able to manage that on an ongoing basis is something that's certainly being considered in the framework and in the system itself. Question is, will opt-out still be through the very consumer-unfriendly MyGov website?
The short answer is yes for online. So there'll be an online portal, there'll be a phone channel, and the agency's working through how else the opt-outs will be done. However, we did get quite a lot of feedback through the evaluation of the opt-out trials around some of the usability issues on the MyGov website. We have provided that to the people who run the MyGov website. So we know that they're undertaking ongoing improvements in MyGov, and we're contributing as much as we can to make that as friendly as possible.
Thank you. What is the definition of dynamic consent that is being used here? I guess, as I mentioned, dynamic consent has a few different meanings, but what we've been taking consultations on so far is that dynamic consent is something that I guess has the consumer at the centre of providing consent when and where they want to, regarding the granular level of data to be able to manage, but also being able to go in and out of providing that consent on certain elements over time and having full control over that, and knowing what's actually consented for, where the outcomes have been achieved or where the consent hasn't been given. So dynamic consent from our consultation so far is quite a broad topic, but one that certainly has been a lot of good discussion around. And the next question is, what will be the default consent for secondary data, yes or no? This will be relevant for the untech savvy or those unable to use the current difficult to use online personal portal. Sorry.
We haven't landed on a position around the default consent. We're happy to take people's views around that. We have heard with poor internet connectivity, with low digital literacy, that it may be difficult for some people to exercise their choices to opt out. So we are looking at if there can be assistance from healthcare providers or others in that space as well. So I don't think we've landed on a position on that, but very happy to take people's views.
The question is, how is it possible for anyone to have trust in what we're being told now, given that in the original consultations around the PCEHR, the forerunner to My Health Record, we were told that records were not for research purposes.
So I wasn't around for the consultations on the PCHR days, but the function for the system operator to prepare de-identified research, de-identified data for research purposes has always been in the My Health Records Act and formerly the PCHR Act. But I can't comment on what was told in the original consultations. I wasn't there.
Yeah, but certainly in terms of developing the framework, one of the key aspects or outcomes from the principles within the framework would be to build trust with consumers and the community around its use, and providing that kind of transparency and framework for that trust to happen. So that's certainly a key objective out of this consultation process, to be built into the framework. So got about 5 minutes or so left. So keep sending through your questions, and as I mentioned at the start, we'll get through as many as we can in the next 5-7 minutes or so, but then we will get reply back to everyone through the CHF on every question that's been sent in today. So the question is, a toolkit for carers has already been released around how to set up a My Health record, and more is coming. Will these resources be updated to include secondary use opt-out?
Yeah, so the communications materials will need to be updated, but I think time frame is important here. So while we'll have a framework in place sort of around March or April next year, there will be an implementation effort to follow. So it doesn't mean that from the 1st of May we'll start getting applications for research and to be considered. So I think there's still a bit of a lead time here in terms of there will be an implementation plan. Data custodian will have to set up governance arrangements and access arrangements. That will all have to be put in place, and at the same time the communications materials will need to be addressed. But it's not an instantaneous thing, because secondary use won't be happening until the implementation plan has been implemented.
Yeah, exactly. I think it's my mum and dad don't have a computer or smartphone. Perhaps aged care facilities might also be a venue to engage with and facilitate consent or opt out for the aged. I guess it's a
Take
comment. Yes, well, obviously, as Nicole mentioned, as we talked about earlier, and certainly in the consultation, being able to make sure that the ability to be able to opt in or opt out and provide consent through a media or medium or person or persons in an easy to use way and a transparent way is certainly a key part of the framework to consider. And we've been taking views on that. I'll certainly take that view in addition.
I know that the Digital Health Agency has a very strong engagement strategy that they're starting to put in place in the aged care sector. So we'll certainly pass that information on to them as well.
Is March the start date for opt-out?
No. So the government has committed to creating a My Health record for every Australian unless they opt out by the end of 2018. I expect it will likely be somewhere mid 2018. It certainly won't be as early as March.
Okay. That'll be part of the implementation plan around how long that takes. And
so the Digital Health Agency is doing a lot of work. We've got an opt-out rule to table in Parliament. We've got technology scaling and infrastructure to do. We've got engagement activities with healthcare providers and consumers to do, and that all takes time to do properly. So the public commitment has been that by the end of 2018, and certainly if we have a 3-month opt-out period, you can sort of assume then that it's mid to late 2018 that opt-out would likely start, but certainly March is categorically too early.
Yes. Question is, will comparative stats be provided for those that opt in versus opt out? That's a question I wouldn't have thought so. I guess if you look at the results for the pilots, I think as Nicole mentioned, the opt outs were in the pilots for opting out. The pilots it was less than 2%.
Yeah, less than 2%. We do have an evaluation report on the Department of Health website that goes through what the difference were in healthcare provider registration, viewing, accessing, uploading, consumers viewing and uploading information to their My Health records during the trial period. And that has some comparisons around the opt-out trials, the opt-in trials, and the opt-out that was running across the rest of Australia. We don't have any intention to re-prosecute that work at this time, but certainly that's on the Department of Health website and accessible now.
Question is, what are the next key dates for this process? Publication of the consultation paper, etc. Framework.
Yeah, so there's been some discussion around potentially publishing the report that comes out of the consultation process. So there will be a report back on the consultation process. We'll receive that in the department very late in December, so that would likely be early next year. And then, as I mentioned, we'll do a stakeholder validation workshop once we have a draft framework, and that's likely to be in February. And then publication of the actual framework will likely be around March or April next year.
Got a couple of minutes left, so we might go do a couple more questions and then we might wrap it up. But as I said, keep putting your questions in. What is going to be done to make sure the data in the record is complete? I've been extremely disappointed in the poor support for the system by my doctors.
Yeah, so this is something we hear a lot from people, and we believe that the opt-out process will help. Certainly what we saw in the opt-out trials was we had a lot more healthcare providers accessing, uploading and viewing information, because from their perspective, I knew I was going to go in and find something. So I knew that I would have a patient, 9 out of 10 of my patients would have a record. So that's quite powerful in and of itself. On top of that, the Digital Health Agency has paired up with all of the jurisdictions who have worked in some jurisdictional readiness plans, and so they'll be working within their state public hospitals and others to make sure that they're uploading, viewing and accessing information. There's a lot more work being done on automatically uploaded information, so that doesn't require the clinician to intervene. So things like discharge summaries, reports of pathology tests and diagnostic imaging reports. There's also a range of engagement strategies in place across specialists, allied health, general practice, and the hospital, private hospitals and aged care sectors to have them uploading information prior to the opt-out period, so that when you move to opt-out, consumers can actually see that they've got meaningful information in their record. In addition to that, we do actually have an incentive for general practice to prompt them to be uploading to the My Health record, and that's had a significant increase in shared health summaries that are going into the system, which allows then a healthcare provider in a hospital to access the record and see that there's something in there that's worth reading, and then that flows on to them uploading more information as well.
Yeah, thank you.
So it's a work in progress.
Yeah, and obviously a key part of the framework that we'll be developing is going to have a quality aspect to that as well. So making sure that when data is requested and being provided, there's a quality aspect to the consideration, making sure that it is as going to be, I guess, of quality and actually not be misrepresented or misused in any way based on the data that's in there. So I guess that's our hour. So we do need to close the webinar now. As I said at the start, keep sending in your questions. We'll endeavour to get back to every person with their questions through the CHF. I just wanted to thank Leanne and also Nicole for their participation today, and as well thank all of you out there on the internet on the webinar today for your participation today. It's been greatly appreciated, and we look forward to receiving your questions and any submissions that you may be doing. Thank you and good afternoon.
Here we are.